Hi, and welcome to Stanford Care's monthly community health talk series. My name's Michelle Engel, and I'm a clinical assistant professor in the Division of Primary Care and Population Health. And I'm also a faculty member of the Stanford O'Connor Family Medicine Residency in San Jose. I'm really pleased to be a part of this series of talks that's co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. And tonight, I'm especially thrilled to welcome Dr. Natalie Louie, who will speak on addressing lung cancer in Asian Americans, screening, treatment, and advancements, which is a topic that many of my Asian patients ask me about. Lung cancer is the leading cause of death for Asian Americans, yet we are the least likely group to be screened. And while lung cancer is traditionally associated with cigarettes, and lung cancer screening is recommended for heavy smokers, studies have shown that lung cancer rates among non-smoking Asian Americans are on the rise, increasing by about 2% every year. So in this session, we'll review the current lung cancer screening guidelines from the United States Preventive Services Task Force, or USPSTF, and explore efforts to increase screening rates, particularly for Asian Americans. Additionally, we'll examine the epidemiology of lung cancer among Asian Americans, covering aspects such as diagnosis, staging, and treatment. The focus will be on the latest surgical techniques used in lung cancer treatment, which is an area of expertise of our speaker, Dr. Natalie Louie, who is an assistant professor of cardiothoracic surgery at Stanford. Her list of accomplishments reads like an Asian parent's dream. Dr. Louie graduated from Harvard with a degree in physics, and then she got her MD degree from Johns Hopkins. She went on to complete her general surgery residency at UCSF, which included 2 years of thoracic oncology research and yet another degree, a master's in advanced studies in clinical research. Dr. Lee then completed her thoracic surgery fellowship at Massachusetts General Hospital, during which she participated in visiting rotations at Memorial Sloan Kettering and Mayo Clinic. Her surgical practice consists of general thoracic surgery with a focus on thoracic oncology and robotic thoracic surgery. Her research interests include intraoperative molecular imaging for lung cancer localization, using artificial intelligence to predict lung cancer recurrence, and, very pertinent to this talk, increasing rates of lung cancer screening. She's also been the recipient of many prestigious awards, including the Donald B. Doty Education Award, which fosters innovative educational initiatives in cardiothoracic surgery. She won the Dwight C. Magoon Award, which is for excellent teaching and mentorship of residents. And then the Carolyn E. Reed Traveling Fellowship, for a female cardiothoracic surgeon to travel to another institution to learn a new technology. And tonight, she is here with us to share her expertise. So without further ado, I'm going to hand it over to Dr. Louie.
Thank you so much, Dr. Engel, and very big thank you to CARE for having me tonight to talk about this important topic. All right, so we will talk about addressing lung cancer in Asian Americans. And as Dr. Engel said, lung cancer causes more deaths than any other cancer. This is true in the United States and worldwide, and among many Asian and Asian American communities. This graph is from the American Cancer Society for expected number of different types of cancer this year in 2024. And the top half shows the estimated new cases, and the bottom half is the estimated deaths. And then you can see on the left side are men and the right side for women. So I'll just highlight here for the estimated new cases for men, and women, lung cancer is second. So second to prostate cancer for men and second to breast cancer for women. However, it's a very deadly disease. And if you look in the bottom half, lung cancer is the highest in both men and women for cancer deaths. So put another way, lung cancer causes about a fifth of cancer-related deaths in the US. So one reason it is so deadly is that it is usually diagnosed when it is advanced. So here you have some images depicting the different stages of lung cancer. Doctors divide all cancers into different stages to demonstrate or to depict how much the tumor has spread or grown. And so here you can see stage 1 through 4, starting on the left, a small tumor in the lung. This is depicted in the neon green. That would be stage 1. But if the tumor has grown enough or has spread to lymph nodes that are close by, then it's stage 2. If it has spread to lymph nodes that are a little bit further away, it's stage 3. And then if it has spread to the opposite lung or to other organs like the brain or bone, then it's stage 4. And you can see that the usual symptoms for lung cancer are none when the tumor is small. People have a lot of normal lung that they can use, and they don't even know. And so it often only starts to cause symptoms at advanced stages. So it could be that the tumor is growing into an airway and causing a cough or causing someone to cough up blood, or it has spread to other areas. For example, if it spreads to the brain, someone might have a headache, or if it spreads to the spine, someone might have a backache. And it is only then when someone would go to their doctor and try to figure out why they're having those symptoms. So when we look at the stage of diagnosis, you can see in the top graph, again, the stages 1 through 4 and the percentage of people diagnosed at each stage. And you can see that the vast majority of people are diagnosed in stage 3 and 4. This is when the cancer is more advanced and has spread beyond the primary tumor. And it's harder to treat. And as a surgeon, I most often operate on people with stage 1 when we know we can remove the entire tumor. And so you can see why surgeons are very excited about opportunities for lung cancer screening. One of the reasons why the stage is so important is that the survival and the treatments depend a lot on stage. So you can see this graph or table at the bottom with the 5-year survival. So that's the percentage of people alive at 5 years after diagnosis. And you can see for the very earliest, smallest tumors, that is above 90%. And then as the stage increases, that 5-year survival really plummets down to less than 10% for stage 4. So it is really important that we diagnose lung cancer at an earlier stage, ideally before people have any symptoms. So the National Lung Screening Trial is the first study that showed that lung cancer screening reduced deaths from lung cancer. This was published in the New England Journal in 2011, and this was a multi-center trial across the United States funded by the National Cancer Institute, and they enrolled over 50,000 people. You can see the criteria there. They were generally older, 55 to 74 years old. They were all heavy smokers, so at least a 30-pack-year smoking history. And they were all either current smokers or quit within 15 years. And they divided this group of participants into 2 groups to undergo 3 annual screenings, either by a low-dose computed tomography scan or low-dose CT scan or CAT scan, or the second group got a standard chest x-ray. And they really found some impressive results. They detected lung cancer in 1.1% of people after the first scan, and half of those cases were stage 1. So that is very different than when we diagnose lung cancer naturally. The important findings from this trial are on the right here. The annual low-dose CT scans decreased lung cancer deaths by 20%. And the number needed to screen was 320. So for every 320 scans, we prevented one lung cancer death. And again, to reiterate, the CT group detected lung cancer at earlier stages. So this trial, the NLST, really started us on the path of recommending lung cancer screening. And the criteria were based primarily on the eligibility criteria in this trial, although they were revised a few years later because of newer data, also including heavy smokers. So here are the current lung cancer screening criteria. And you can see they changed slightly from the original NLST study. So these are people aged 50 to 80 with at least 20 pack years of smoking history, and then either current smokers or quit within the past 15 years. And the recommendation is an annual low-dose CT scan for as long as people meet these criteria, as well as smoking cessation if someone is currently smoking. And so because of the NLST trial, the US Preventive Services Task Force recommended lung cancer screening. And then a couple of years later, the insurance companies started covering it. And so currently, people who meet these criteria are covered by their insurance to get an annual low-dose CT scan. Just to clarify one term, pack year, it's a question I get often. This is calculated by multiplying the number of packs smoked per day by the number of years smoked. So there are many different ways to get to the threshold criteria of 20 pack years. A couple examples are here. Someone who smoked 1 pack per day for 20 years has 20 pack years, but also someone who smoked 2 packs per day for 10 years also has 20 pack years. So doing that quick math will show you whether someone meets the criteria for lung cancer screening. Here's a slide about the low-dose computed tomography scan. You can see a picture on the right that it is this neon tube here, and the person will lie down on that bed and then essentially get moved into the scanner. And it really just takes a few minutes. The radiology tech will make sure that the person is comfortable and then step outside the room and give instructions to take a deep breath and hold it just for a few seconds. For the LDCT screening scan, there are no IVs or needles involved. No contrast is required. It does not hurt. It is very easy. And so some people might ask, well, why don't we scan everybody then? But there are some risks to the scan. So most people know that there is some radiation exposure. This is about 1.5 millisieverts for the low-dose computed tomography scan. This is similar to 6 months of background radiation. And just in comparison, a normal diagnostic CT scan has 6.1 millisieverts, and then an X-ray has 0.1 millisieverts. So it's not something that we want to do frequently, especially in younger people. A couple of the other risks include finding lung nodules that are worrisome but benign. We call this a false positive. We can definitely find lung nodules that look concerning and might even lead to additional scans or procedures. And some of these may end up being benign, not cancer. And so that person has undergone potentially unnecessary tests. Another potential risk is that we find a slow-growing lung cancer, something that would have grown so slowly that it never would have hurt someone. I think physicians are getting better at determining which nodules are like that. And then finally, there's a lot of anxiety at times in terms of finding abnormal things, or even undergoing the scan can cause anxiety, and the cost of the scan. The LDCT results, well, the LDCT is read by trained radiologists, and they classify the results into this categorization system called lung rads. And you can see that they number them from 1 through 4 based on how suspicious the finding is. And so people who read the report from their LDCT might see this lung rads with a number. And so you can see here this ranges from a negative finding, benign, probably benign. And then once you get to 4, these are the ones that are more suspicious for lung cancer. And on the right-hand side, you can see the general recommendations based on the finding. So for negative or benign findings, continuing the annual low-dose CT is recommended. As the finding becomes a little bit more worrisome, we may order the next CT scan a little earlier than 1 year so that we can follow any abnormality closer. And then for the findings that are very suspicious, we might actually proceed to tissue sampling, like a biopsy or even surgery. Interestingly, there's this last category S for significant or potentially significant finding unrelated to lung cancer. And so we sometimes find other abnormalities, such as coronary artery calcifications, aortic pathology, sometimes other diseases that can be seen in the chest. So since the NLST was published in 2011 and lung cancer screening was started to be covered by insurance in 2015, that is almost a decade ago, we still have had a lot of challenges in screening. On the left, you can see data from the American Lung Association, and each bar is a state with the percent of eligible people who are getting screened. And you can see this is terrible. It ranges from almost 12%, that's a small minority of people who are getting screened, all the way down to California at 0.7. Now, there has been some more recent data that estimates California isn't doing that bad, more like around 15 to 18%, which is still pretty terrible. And so we have really been trying to do a lot of outreach to increase the screening rates in heavy smokers. On the right, you can see the results of a survey we did at the Stanford Health Matters fair last year. We asked people attending the health fair, did you know there's a way to screen for lung cancer? And 71% said no. Now, we've been talking about lung cancer screening for heavy smokers, but we do know that lung cancer in Asian people is different. So there are a few different aspects that really distinguish this type of lung cancer in many Asian people. First, the type of lung cancer is more likely to be a kind called adenocarcinoma. They often have mutations such as the epidermal growth factor receptor or EGFR mutation that's within the tumor. Asian people with lung cancer are more likely to have never smoked, and they're often more likely to have ground glass or part solid nodules. This is an example of a ground glass or part solid nodule. So you can see this is an image from a CT scan, and you can see how much detail we have in the lungs, even from a low-dose CT scan. And this is a cross-section of someone. You can imagine them standing up and looking back at us from the screen. And the two dark areas on either side are the lungs. And then the white in the middle is the heart. And you can see that the lungs have little black and white dots in them. And most of those are normal blood vessels that are found in the lungs. But this area where the red arrow is pointing to, there's a little bit of haziness and white there. And that haziness is what we call ground glass. And that can mean ground glass in the lung can mean a lot of different things in general. It can represent infections or inflammation in the lung. When people were initially diagnosed with COVID, they would come in with large areas of ground glass in their lung. But we do know that if an area of ground glass remains consistent over time, it may be what we call an adenocarcinoma spectrum lesion, meaning it could be a precancerous or an early cancer. And then we often follow these ground glass nodules because they grow quite slowly. And we follow how the total size, how quickly they're growing, as well as if they solidify. So in this nodule, you can see a little area within the haziness that's a little bit more white or brighter, and that we call the solid component. So we also follow that part of the nodule. And depending on the patient and the circumstances, we will discuss with them when it's time to act on it, to either get a biopsy or treat it. This is data from an Asian American study where they looked at the people who had been diagnosed with lung cancer and the proportion of them that had never smoked. So you can see here that the group of white participants was all the way to the left. And then different Asian groups are depicted all the way to the right. And you can see that the percentage of never smokers in Asian women in red was much higher compared to the white group, over 80% in the Chinese group all the way to the right. And the proportion of never smokers in men was also much higher in the Asian groups, but not as high as women. And there has been a lot of investigation as to why this might be. And we don't have any really clear answers yet. So part of it is likely genetics. Secondhand smoke may account for some of these cases. Air pollution, especially in large cities in Asia. And then finally, cooking oil fumes. So there has been some inconsistent data, but some positive data that cooking oil fumes and exposure to oils on the stove is associated with lung cancer. So we do recommend that if people cook on the stove, that they use a vent over the stove and open windows so that there is ventilation in the kitchen. So the lung cancer screening recommendations that we talked about earlier are all for heavy smokers. But because these Asian communities found a lot of never smokers who were developing lung cancer, there have been several areas in Asia that started offering screening. And one of the most developed programs is called the Taiwan Talent Study. And they enrolled over 12,000 people aged 55 to 75 who were either never smokers or very light past smokers. And all of them had at least one additional risk factor. That could be family history, cooking oil exposure, secondhand smoke, asbestos exposure, tuberculosis, other lung disease. And they received a low-dose CT scan annually for 3 years, and then every 2 years for another 6 years. And they published their results earlier this year and found that the lung cancer detection rate was 2.1% after the first scan. So if you remember, the detection rate was 1.1% in the NLST with heavy smokers. This is almost double. Again, they found that about half their cases were stage 1. All but one were that type of cancer, adenocarcinoma. And family history ended up being a really big risk factor. The detection rate was even higher, 2.7% in participants with family history. So because of this study, Taiwan launched the early detection program last year. And so they are currently offering screening to never smokers who have a family history of lung cancer, starting at age 50 for men and age 45 for women. And unlike the recommendations for heavy smokers in the US, where we recommend a scan every year, Taiwan is now offering that scan every 2 years. Now, in the US, there really is only one trial so far that's screening never smokers. This is run out of NYU and it's called the Female Asian Non-Smoker Screening Study, or FANS. And they reported their initial findings last year with the first 200 participants. So they're enrolling women never smokers who identify as Asian, starting at age 40, so quite young. And they are performing the low-dose CT scan annually for 3 years. And in the first 200 participants, they detected 3 lung cancers, so their rate was 1.5%. All 3 had EGFR mutations. Now, interestingly, their detection rate for ground glass nodules was 14%. So these may, in the future, develop into lung cancer. So I'll talk just briefly about the treatment of lung cancer. We often divide treatment into 3 types: surgery, radiation, and systemic therapy. Surgery is performed by a thoracic surgeon. Radiation is given by a radiation oncologist. Both surgery and radiation are considered local therapies, so they affect the tumor itself. And then there's a category called systemic therapy that's given by a medical oncologist. Most people are aware of chemotherapy as one type of systemic therapy. And with lung cancer, we've had real advances in our options for systemic therapy. These include immunotherapy, which essentially harnesses the immune system to fight the cancer, as well as targeted therapy. And so these are specifically for tumors with mutations that includes EGFR or other mutations like ALK or ROS. And those mutations are all more common in people who have never smoked. So I will now end with an example case, one of my recent patients whose lung cancer was found through screening. So she had quite a heavy and long smoking history and was recommended to get screening by her primary care provider. And so you can see I put images of her screening scan at different angles up here just so you can see how much detail we get in these 3D pictures of the lung, even with the low dose. And I'll just show you in the middle one again that the tumor is right here. Hopefully you can see my arrow. So this is in the left upper lobe. And you can see this screening scan. When we look at the characteristics of this tumor, it's a bit irregular on the outside, and that makes it more suspicious for lung cancer. And so this was classified as a lung RADS 4A, and that means suspicious for lung cancer. And so her physician ordered a CT-guided biopsy. So here you can see that one of the interventional radiologists is using a CT scan, again, with a small needle to get a small sample of the lung nodule. And indeed, this was evaluated by a pathologist and found to be adenocarcinoma. So she came to see me, and I ordered a PET scan, positron emission tomography. And this is a type of scan that shows us the metabolism of the cells, and it is used for staging lung cancer. And so here you can see the lung nodule is a little bit red on this scan, and that shows that the metabolism of those cells is higher than the rest of the cells in the body. And more importantly, while the tumor was a little bit hot on the PET scan, there was nothing else that was lighting up. And so this was stage 1 lung cancer. So we took her to surgery, and here's some pictures of the robotic operation. So on the left, you can see me and a colleague operating at the console. So we're actually not next to the patient. We're looking into the console and using hand controls. The middle picture shows what we're essentially looking at in the console, a very detailed magnified image. And then you can see the robotic instruments here that all fit through these small ports between the ribs and let us do fine detailed work through these small incisions. And then on the right, you can see a picture of the robot itself. So the robot has these arms, these white arms that hook into these small ports, metal ports that go between the ribs. And then there's a camera, and all of us are looking up at the screen at the camera, and you can see the nice pink lungs here. So we have one of our physician assistants at the bedside helping with the robot. So we removed the left upper lobe of her lung and also lymph nodes all around the area. And the pathologist reviewed the specimens and confirmed that it was a stage 1 lung cancer. So she does not need any other treatment. And in fact, she just came back for one of her surveillance scans, and there was no evidence of any tumor, residual or recurrent tumor. So we are very happy, and she will not require any other treatment and continue surveillance. So thank you so much for your attention tonight. I have the lung cancer screening clinic number here if you have any questions about screening. And then just some announcements. CARE is starting a non-smoker lung cancer initiative, and we are planning a 2-day summit in March about non-smoking lung cancer. So you can check out CARE's website here for more information. And we are planning a couple trials in the near future. Our own LUNA trial to screen Asian never smokers, as well as a trial to test an ultra low dose computed tomography scanner to see if we can reduce some of the risks of lung cancer screening. Thank you so much for your time, and I am happy to take questions.
Thank you so much, Dr. Lee. We, I think, all learned a lot of great information from your talk. And as I'm looking over the questions now, I realize that there are quite a few of them, and I'm pulling from questions that were submitted beforehand, as well as questions that are submitted here through the Q&A live. And there's a theme to some of the questions that go along the lines of, is blank associated with lung cancer? So for instance, to the best of your knowledge, is vaping associated with lung cancer?
Yes, I get that question a lot, and we don't have definitive evidence that's associated, but in general, my recommendation is not to inhale any substances that you don't need to. So smoking, vaping, any other chemicals, I think we would recommend avoiding that exposure.
Great. And what about radon and lung cancer?
Yes. So radon is a known risk factor for lung cancer. And it is pretty tricky because a lot of people don't even know about it. Um, you can order radon tests online. I think the American Lung Association has some, or um, if you Google it, you can find some. And there are a few different radon tests, long-term and short-term tests, if you would like to evaluate your home. It can be a bit expensive if you find that there's high radon levels to extract it, but something to look into if you are worried about that.
Mm, thank you. And you talked about the connection between cooking oil exposure and lung cancer. What about cooking with gas stoves?
I don't think there's any data about cooking with gas stoves as opposed to others, not that I know of. I think most of the research has been done mainly with the oil fumes themselves, well, there have been some in terms of type of energy like coal, uh, in terms of the energy used for cooking, and that is a risk factor. But I think that's very rare in the US.
We have some so interesting musings via the Q&A. For instance, if cooking oil is a potential causative factor and most of the chefs are males in a Chinese restaurant, why do they have a lower rate of lung cancer than the never smoke cancers?
Well, I do think the graph that I showed was the proportion of never smokers. So I don't think we know a lot about the what jobs people had, or and I do think that probably there are not that many chefs as a proportion of the population, especially compared to people cooking at home, which is often women.
Mm. And there were quite a few questions about the relationship between lung nodules and cancer, and specifically about the size that might cause concern.
Yes. So a lung nodule is an abnormality in the lung, and that can be cancer or precancerous, but it could also be benign, meaning not cancer. And so when we get a scan, we look at different characteristics of the lung nodule to determine how worried we are about lung cancer. And so one of the characteristics is size. So the larger it is, the more worried we are. But that doesn't mean that something is definitely cancer because it's large. I've had patients come in with a really bad pneumonia and they'll have a large mass in their lung, but that was just an infection, an inflammation in their lung and not cancer at all, and it goes away. But we do have to keep all of the risks in mind. So when we get a scan and see a nodule, we take these risks into account and decide how to follow up on that. So for example, if something is really not worrisome, we might say get a scan in a year. Whereas if it is more worrisome, we might actually get a scan in just a few weeks because we don't want to allow something to grow without us knowing if we think that it might be cancer. And if it's really suspicious, then we might not get any additional scans and just send the patient for a biopsy or even surgery immediately because we feel that it's so worrisome for cancer.
Mhm. And tying in the detection of these lung nodules, and what you shared about the lung cancer screening protocol for smokers, what are the current guidelines for non-smokers, like the Asian population at higher risk for lung cancer? And do you think there's anything that could change that in the near future?
That's a great question. So, right now in the US, there are no guidelines for never smokers. So it really is only people who have a heavy smoking history that are recommended by the US Preventive Services Task Force and that are covered by insurance. I do think that there's a lot of data coming from Asia about screening never smokers, but it is not covered in the US. So my main recommendation is that if someone's worried about it, that they talk to their physician about it. Essentially, in the US, they would have to pay out of pocket for the scan. And our lung cancer screening clinic is happy to talk to people about it as well. So you could call our clinic and make an appointment and talk with our team about the risks and benefits of screening and whether you want to pay for it.
Mm. That sounds like an excellent resource. And I will add from the primary care perspective, I have had patients, non-smoking patients who don't qualify for insurance covered lung cancer screening who have paid out of pocket, I think over $1,000 for the CT. And I've had other patients who have gone back to mainland China or Taiwan to do the scans there, and they will bring me back the results that we help to follow up on.
Yes. At Stanford, the scan costs $550 if you don't try to get it covered by insurance, and then $630 if you do try but fail. Then that's the out-of-pocket cost. But I have the same experience that you have had, where many of my patients have gone back to Asia to visit family or go for work, and they are many times offered scans, even if they're young or not meeting any of these criteria. And they're the ones who will come back and get care here.
Mhm. And you mentioned too that family history seems to be a genetic component of lung cancer for non-smokers. When it comes to family history, does it matter if it's a first degree relative, second degree, third degree?
Yeah, so the most data we have on this is from the Taiwan talent study, and they did show that they they the more family members you have, the more at risk you are, and the closer the degree of family member, the more at risk. So people who had a first degree had a slightly higher risk than second degree and third degree.
Mm, got it. And do you know of any cultural or psychological factors that might influence how Asian Americans perceive or access treatment to lung cancer?
Another good question. I think this is a very, very big topic, and there's been um, many studies, not just in lung cancer, but in cancer care in general for Asians and Asian Americans. I think that there have been a couple big themes that I have read about and experienced. I think one is that there is often a language barrier, and so it is important for people to get the right health information in a language they understand. And I know at Stanford, we're very lucky to have interpreters for all different languages immediately available for us, but that is really important when taking care of the Asian American community. And I'd say second is some of the uh, I'll call it stigma of lung cancer. So there are some people who don't want to tell their family or friends about it, and they're kind of going through the care of their cancer more alone or without as much support. And then sometimes the flip side. So sometimes there are um, adult children of patients who are sometimes interpreting for me or for their family, and they don't want to tell their older family member because they are, worried that they'll be too stressed or too anxious about it. And so I think keeping these in mind and making sure that people are getting the information they need is really important.
Mhm. Thank you for sharing that. There are also several questions here about diagnostic testing for lung cancer. So we talked about lung cancer screening. So that's in the absence of any symptoms, just automatically done across the board. So some people are wondering about diagnostic testing for lung cancer. So what sort of symptoms might they want to report to their doctor that could be connected to lung cancer?
Yes, well, you could see from the slide that there's different symptoms that can be caused by lung cancer, but they have a lot of other causes too. So things like cough. There are so many different reasons someone might cough that is not lung cancer, but it's something to keep in mind. So if you develop a cough and all of the usual treatments are not working, then it might be worth it to get that CT scan to figure it out. And that's a discussion with your doctor. I wouldn't necessarily jump to a CT, and you know better than me as a primary care physician. You can't get a CT for everyone who comes in with cough. And similarly with other things like back pain, you wouldn't normally think, or headache. There are other evaluation or other tests to do first. But eventually, if the other tests don't show anything or other treatments aren't, it's good to keep in mind that there are these other more rare causes of these symptoms. Um, there are a few symptoms that I think would really make you jump to lung cancer. For example, coughing up blood. It would make me much more worried, and I wouldn't wait on something like that.
Mhm. Yeah, I absolutely agree. I think of my patients who present with chronic cough to clinic, the majority thankfully have something else. It could be allergies, could be asthma, it could be reflux. And so I think thinking about some of those more severe symptoms, coughing up blood, unintentional weight loss, unexplained fevers, night sweats, definitely make us think more about cancer. And it's specifically too, if other workup is concerning, we usually start with something like a chest x-ray. So zero point 0.1 millisieverts to see if there might be something suspicious. And then we usually take a stepwise approach to diagnosis from there.
Mm.
So moving into the surgery side of your practice, for a stage 4 lung cancer patient, what factors would influence the decision to consider surgery as part of the treatment plan?
Mhm. So it's pretty rare that we operate on stage 4 disease. So that's lung cancer that has spread to another organ in the body. And so generally, the only time we will remove the tumor is if it has really spread to a very low number of places. For example, if there's one brain metastasis, then we might consider removing it. But really, the mainstay of treatment for stage 4 is systemic therapy. I will add there are things that we can do for palliation of stage 4. So if someone, for example, has a pleural effusion and fluid around their lung that's causing trouble breathing, then there are sometimes small procedures that we can do to make people more comfortable from that.
Hmm. Got it. And there's also a question here about whether you know of any news on mRNA vaccines against lung cancer.
Oh, I I don't know. I think I am not the right person to answer that question.
Got it. Let's see. We have a lot of great questions here. People have certainly asked about what can we do to help change the policy around screening for lung cancer for Asian Americans.
Yeah, that's a good question. Well, we are really trying to raise awareness and also um, raise funding for research into this topic. I think it's really hard to change the guidelines without good research behind it. So you can see the National Lung Screening Trial, which really changed the whole world of lung cancer screening almost a decade ago. That was a study of 50,000 people, and that's how they proved that screening really worked. And so you can see it takes a lot of effort in order to really prove that things are helpful in medicine and change those guidelines. I'm hoping that we will, or that we'll learn more about this.
There's also a great question here about how quickly lung cancer develops and grows, and whether screening every 2 years, like they're doing in Taiwan, is enough to catch a tumor before it goes from one stage to another. Could it go from early to advanced within 2 years?
Yes, so there is a really wide range of the rate of growth of lung cancer. So there are definitely cancers that can grow from a small size to widespread within a couple years. That is definitely true. But there are also these part solid nodules, or the ground glass nodules that we discussed, that are generally slower growing, and in some cases extremely slowly growing. So I have patients who have ground glass nodules. We've been watching them for many years, and we're not planning to do anything about them until they grow to a certain size or really show that they're expanding and getting more aggressive. And we find these more in never smokers. And so I think it is important to balance the risks of the screening scans with this true benefit of finding lung cancer early. And these are something that we really don't know the answer to quite yet. But I do feel that since these are more common never smokers, that the current Taiwan guidelines of every 2 years is very reasonable.
Mm. And do you have a sense of what the median age of death is of Asian lung cancer patients, and whether there's a difference between male patients and female patients?
Mhm. I don't know the median age of death. I will say that in general, lung cancer is still more common in older people. But we do know that there are never smokers who are diagnosed when they're quite young, and that does seem to be a little bit younger in never smoking women. And so I think that is reflected in the current Taiwan criteria, where they start at age 45 for women and 50 for men. Those are people with family history. And I think the study at NYU is trying to look into that too. They start screening at age 40. So we know that there is this risk, but the risk of the radiation exposure is also higher in the younger someone is. And so I think, again, there are a lot of questions that we need to figure out so that we balance the risks and benefits of screening.
Mm, yes. A couple other people had asked question along those lines, weighing the risks and benefits of why in Taiwan do they stop screening at 74, and then we here stop screening at 80 for our current smokers or have
Yeah,
smoking.
that is a really good question. So, one of the things that I didn't mention was that the screening is really to diagnose lung cancer so we can treat it. And so, we generally don't recommend screening for someone who could not or does not want to get treated for lung cancer. And so a lot of our screening really should be in people who are healthy enough to undergo treatment. So even though the guidelines, and this is what is covered by insurance now, goes up to 80 years, if there was a healthy 81-year-old who felt that they could undergo treatment for lung cancer, I would recommend continuing to screen. It just wouldn't be covered. So I think that is a little bit tough. And another decision to make, I think, if someone ages out of lung cancer screening guidelines.
Mm. And there's someone here who had mentioned that there is a FAN study, so a female Asian non-smoking study being done at UCSF and Stanford and
Yes.
recruiting participants.
Yes, and so this is a little confusing because there are two FAN studies, and the one here at UCSF and Stanford has one S, and then the one at NYU has two S's. And so, yes, the FAN study is recruiting healthy participants to serve as controls, as well as collecting data and tissue samples from women never smokers who develop lung cancer. And so they do have a website where you can sign up.
Great. So yes, we encourage you to sign up if you qualify for those studies. That would definitely help us get more data about this topic.
Yes, thank you, Nina, for putting the website in the chat there. So just to be clear, they're not screening people, but you can still join. The FAN study in New York is the one that was screening people.
Great. And what is your impression of genetic screening tests that are out there, like Gallery, for instance?
I think that there's more research to be done on them. So I think we're really starting a very exciting time in medicine with these multi-cancer early detection tests. And to be able to diagnose lung cancer using a blood test would be amazing. But it's not FDA approved. It's not a good replacement for CT scans at this point.
Mm.
But I am excited and hoping that in the near future we have options like that for people.
Mm. And here's a question that's near to dear to my primary care heart, which is there anything that we can do to improve our lifestyle, the way that we live, besides not smoking and reducing exposure to cooking oils that could prevent us from getting lung cancer?
Mhm. Well, I think you hit on the main one, which is not smoking or quitting smoking. That's really the primary risk factor for lung cancer that we know of. That's why the current screening guidelines are all about smoking history. So quitting smoking or not smoking is the most important thing. And then really just making sure that you're taking care of your lung health. So avoiding the cooking oil fumes, using a vent over your stove, opening windows in your kitchen, avoiding exposures like wildfires, smoke, making sure that you're using an air filter or a mask. If we do have a lot of smoke in the air, I would recommend really not inhaling any other chemicals that are not necessary there. If you are concerned about radon, you could check that. And then really, I think otherwise just maintaining a healthy lifestyle.
Mm. Sounds great. And it looks like we have time for one more question, which is reflecting back on the last 5, 10 years of the treatment of lung cancer. What are some of the greatest improvements that you've seen in the field?
I think that we've made so many advances over the last decade or so. I'll just start with surgery because I'm a surgeon. We've really increased the number of minimally invasive operations that we offer patients. So these are operations done with smaller incisions using a camera instead of a big incision, and patients have less pain and recover faster from them. In radiation oncology, we've developed stereotactic techniques to really treat tumors themselves while giving a very low radiation dose to the surrounding lung and other tissues. And then, especially in medical oncology, the advent of targeted therapies and immunotherapy have really just transformed the way we treat advanced lung cancers.
Mm. Wonderful. It sounds like there is much too on the horizon that we have to look forward to. So thank you so much, Dr. Louis, for your work in this field and for sharing that knowledge with us for this very important talk. And we welcome everyone to the next Stanford Care Monthly Talk, which will be on October 10th.